Welcome back to the deep dive. Today, we are opening up a file on, well, one of the most pressing issues facing developed nations everywhere. How do you pay for healthcare when your population is getting older and the costs just keep going up and up?
Yeah, it's a huge challenge.
We're looking at a specific policy battle happening in Japan, but trust me, the financial and the ethical problems here, they're a preview of what's coming for everyone else. Okay, let's unpack this.
So Japan has one of the world's most rapidly aging populations. It's a well-known fact. And their national finances are under just tremendous strain.
Right, so the government is scrambling.
They're looking for any way to trim medical expenses without, gutting the really essential services. The big proposal we're looking at is removing public insurance coverage for a very specific class of drugs.
Okay, so what are we talking about?
That's right. Our mission today is to analyze the sources on this proposal, which targets what are called OTC.
Okay, what does that mean?
It translates roughly to OTC-like prescription drugs. So these are prescription medicines that have, well, basically the same active ingredients or the same effect as something you can just buy over the counter.
Without a doctor's note.
Exactly. The policy idea behind it is pretty straightforward, fiscally conservative.
I can imagine.
If you can get a non-prescription version pretty easily, the argument is that the cost of the prescription version should shift away from the national insurance system.
Yeah.
It's about moving things considered conveniences off the public tab.
And this isn't just a minor tweak, right? The scale of this it's massive.
Oh, it's huge.
There was one politician, Inos, who identified 28 specific active ingredients to be excluded immediately.
And he was very specific.
Yeah.
He focused on prescription drugs where the maximum daily dose is exactly the same as the OTC version.
Which suggests there's no real safety argument for keeping it prescription only.
Precisely. And that targeted list, just those 28 ingredients, represents an annual drug cost of $154.3 billion.
Wow.
That's about $1 billion US.
Yeah.
Just in annual spending that they believe could be taken right off the public books.
So let's jump right into the specifics then. To get why this is such a big deal, we need to know what medications are driving that incredible cost.
Yeah, what are these things?
These are the drugs that, when you see the price tag, you can understand why citizens feel like insurance funds are just being wasted.
And the data shows that most of that $154.3 billion is really concentrated in just 3 types of drugs.
Okay.
It shows you how common they are in just everyday medical practice.
So what's number one?
The most expensive, by a long shot, is a heparin analog substance. You might know it by the brand name Hirudoid. That costs $54.4 billion a year.
$54 billion. Okay.
Second is magnesium oxide, which is just a very, very common laxative. That's $23.1 billion.
And third?
Third is Fexofenadine. That's the anti-allergy medication sold as Allegra in a lot of places. That comes in at $20.3 billion.
Hold on. $23.1 billion for magnesium oxide? That's a basic chemical compound. It's super cheap. The cost has to be pure volume, right?
Precisely. It costs almost nothing to produce. The fact that it adds up to over 20 billion yen just shows how routine the prescriptions are.
So doctors just tick the box.
A patient mentions slight constipation, the doctor ticks the box, and insurance pays. That ease of access just drives up the volume.
What's fascinating here is the safety nuance behind this whole debate.
Yes.
Yes.
You might wonder, why are these prescriptions only to begin with? Well, normally, OTC drugs have a lower maximum daily dose than the prescription version.
As a safety measure, right?
Exactly. It gives the OTC version a broader safety margin for when people self-medicate, but it might make it a little less potent.
So the OTC is safer, but maybe weaker?
That's the general idea.
Yeah.
But the 28 drugs that Inos targeted are different. Their max prescription dose is the same as the max OTC dose.
Which undermines the whole argument for keeping them subsidized.
It completely undermines it. From a safety standpoint, they're already considered to have a very broad safety margin.
But if the dosage is the same, why aren't doctors just telling patients to go buy the OTC version? Why keep prescribing it?
That gets into the systemic incentives, which we'll get to. But for the patient, it's simple. 0 copay versus paying full retail price.
Right.
For policymakers, the conflict is clear. People need moisturizers, laxatives, allergy meds. But since they're already available over the counter and deemed safe, the government is saying they should be bought without using the public safety net.
And the situation gets a lot messier when you look at how the system is actually being exploited. This is what really erodes public trust.
Yeah, the anecdotes in the source material were Pretty incredible.
I thought the story about the cream, Hirudoid, was particularly telling. Medically, it's for hives, bruising, but it became really popular as a cosmetic.
Like a powerful anti-aging cream.
Exactly. And the story was about a patient who went in for a rash and, without even asking, walked out with 10 tubes of Hirudoid because the doctor just offered it.
And that story just perfectly shows how easily the system can be abused. If a doctor is handing out 10 tubes of a cosmetic favorite,
For a minor issue.
it really makes you question their criteria. Are they prescribing for medical need or, for patient satisfaction? Or to boost volume?
And that volume abuse leads right to another problem, the add-on prescription.
Yes, this involves exploiting loopholes in systems that were set up to protect vulnerable people, specifically in places with free medical care for children.
The goal there is so noble, right? To remove any financial barrier so a sick child gets seen immediately.
It's a crucial safety net. But what started happening is some parents began using their child's free doctor visit, say, for a cold, to get these cosmetic drugs prescribed for themselves.
So they're getting Hirudoid for themselves, but it's being covered under their child's free medical care.
Exactly. They get a high-demand cream for free, totally bypassing the whole point of the system.
If we connect this to the bigger picture, these individual examples have a huge negative impact.
The picture is pretty sobering. It's not just the cost of a few tubes, it's the cumulative effect. This leads to explosive, unnecessary growth in medical costs.
Which puts more pressure on the whole insurance system.
And crucially, it pulls resources away from people with truly life-saving needs.
And the most painful part is probably the decline in public trust. I mean, if you're a taxpayer and you know your money is subsidizing luxury creams, why would you trust the system to be sustainable?
Exactly. Integrity is the foundation. Once that starts to crack because of all this visible abuse, support for the entire thing just weakens.
If we connect this to the bigger picture, the challenge here is really complex.
It's twofold. You have to cut the waste, but you also have to protect the most vulnerable patients and the supply chain itself.
Right, because there is a very strong counter-argument to just cutting off coverage completely.
Absolutely. Think about someone with a chronic condition, like severe atopic dermatitis or chronic dry skin.
They need huge amounts of these creams.
Potentially dozens of tubes a month just to manage their condition and prevent painful flare-ups.
So if they lose insurance coverage for that, the economic burden isn't just an annoyance, it becomes a massive prohibitive cost.
It could easily run into hundreds of dollars a month. And that forces a choice no one should have to make. Manage your chronic illness or pay your rent.
They might just abandon treatment.
They're very likely to abandon treatment, which creates a whole new public health risk that could be even more expensive in the long run. Protecting those high-need patients is vital.
And this brings us to the pharmaceutical companies. This adds a whole other layer of complexity. We need to talk about Japan's drug pricing policy, the Yakuka system.
Right. Under this system, the government sets the price of prescription drugs. And for older, long-listed drugs like the ones we're talking about, those prices get cut every single year.
So the price just keeps going down.
It can get driven so low that it actually falls below the company's cost to manufacture it.
So they're losing money on every prescription they sell.
That's the impossible position they're in. They can either keep supplying the money-losing prescription version, which they often have to do by law if there's no alternative, or they make the rational economic choice. Stop supplying the unprofitable prescription version and focus entirely on the more profitable OTC market.
So if the government pushes too hard, the manufacturers might just stop making the prescription version altogether.
And then even the patients who truly need it might lose access to that reliable, large-volume supply. It's a perfect storm of systemic risk.
The problem isn't just one thing. It's not just patient abuse.
No, it's deeply embedded in the financial structure, drug pricing, and just the basic need for companies to stay in business.
So we've covered the what and the who. We need to get to the why. Why does this misuse happen? It seems like a whole web of factors.
It is.
We talked about physicians prescribing what patients want to boost satisfaction, but there's also a structural incentive. The fee structure itself.
That's the UU system, the consultation fee structure. It's not just about pleasing the patient. The sources suggest that the fee a doctor gets is often tied to the volume and complexity of services provided, including prescriptions. So more prescriptions can mean more revenue.
A very real financial reason to overprescribe.
And then, of course, there's patient psychology, that feeling of, well, if it's free, I might as well get it.
And all of this is happening because of, what, weak surveillance, weak penalties?
A weak system of surveillance reporting and, crucially, penalties that just aren't strong enough to deter the abuse.
This raises an important question. How do you fix all of this? How do you fix the system's weaknesses while still making sure people who need these drugs can get them?
The source material actually details 4 pretty compelling reform ideas.
Okay, let's start with the administrative side. The first proposal is about reporting and accountability.
Right. Because fraud is so hard to detect from the outside, the proposal calls for mandatory, anonymous internal reporting and strong whistleblower protections.
We've seen cases where the Ministry of Health itself has been slow to act on complaints.
Way too slow. So the system needs a legal push. The idea is to have laws that mandate an investigation within a short, specific time frame after a report is filed.
And penalties for the administrators if they don't act.
Exactly. You have to penalize the enforcers if they fail to enforce.
Okay, that covers the administrators. What about the doctors and patients? That's proposal 2.
Stricter penalties. It's absolutely necessary. Japan's current penalties for this kind of fraud are, well, often too weak to be a real deterrent.
So harsher fines?
Substantially harsher penalties and fines for doctors who engage in this kind of prescribing and for patients who knowingly submit fraudulent claims. The punishment have to fit the crime.
And proposal 3 goes right back to that loophole with the children's free medical care system.
Right. To stop that misuse, the proposal suggests changing it from being completely free at the clinic to a pay and reimburse model.
So parents would pay the standard 30% copay up front.
And then get reimbursed later by the local government.
That sounds like a good way to reduce misuse because it adds some friction. But is there a risk that it could hurt low-income families? That they might avoid a necessary visit to save that initial money?
That is a crucial point, and the sources do acknowledge it. But the argument for this model isn't just financial, it's psychological.
How so?
That small act of paying, even if you get it back, instills the understanding that medical care has a cost. It breaks that mindset of free means get whatever you can.
So the friction is a behavioral deterrent.
It closes the loophole for cosmetic misuse while keeping the system accessible for real pediatric needs.
And finally, proposal 4. This is about protecting those vulnerable chronic patients.
Yes, we have to ensure they have reliable access. The solution isn't to just remove insurance coverage for everyone, but to build a smarter safety net.
Okay.
The proposal is to expand the existing subsidy systems, the ones they have for specific high-cost chronic diseases, to cover high medical costs for other deserving conditions.
So the subsidy would be based not on a specific diagnosis,
but on the patient's actual financial burden from their high-volume needs. It protects the legitimate patient while taking convenience seekers off the general insurance tab.
This has been a really detailed analysis. We started with the immense pressure of rising healthcare costs and this proposal to cut coverage for OTCU. And we've seen this sharp tension between fiscal responsibility saving that $154.3 billion and the absolute need for patient access for vulnerable groups.
And all of it is complicated by systemic misuse, profit-driven prescribing, and that flawed drug pricing system that threatens the entire supply chain.
So what does this all mean? The challenge facing Japan, and really every nation with a social safety net, isn't just about spreadsheets and cutting costs.
No, it's not.
It's about ethical behavior, it's about institutional integrity, and just maintaining the viability of a vital social resource. What we're seeing in Japan is a preview of the same stress-facing systems everywhere. Where do you draw the line between a subsidized convenience and a subsidized necessity?
And I think the security of the public insurance system, it ultimately depends not just on smart policy, but on the actions and integrity of every single person who interacts with it.
Patient, doctor, administrator.
Everyone. You have a direct, if small, role in safeguarding its future. Because every decision about what is necessary versus what is convenient, well, it has ripple effects. It determines how much capacity the system has to care for the next person in line. Something for you to consider the next time you leave the doctor's office.